Welcome dear doctors to 𝗲𝗵𝗵𝗺. I am Dr. 𝗲𝗵𝗵𝗺 and I am your pediatric faculty. We are discussing about the newborn examination, and as I have told you that newborn examination is a very important part. Whenever any examiner is going to come, is going to ask you questions related to practicality, related to your theoretical knowledge. For both of them, craniofacial abnormalities are important. And of course, for the competitive exams, some aspects of craniofacial abnormalities are really important. And of course, for the exam of your life, when the patient is going to come to you, you have to treat them, and for that, the knowledge of craniofacial abnormalities are extremely important for even an MBBS graduate to at least identify the abnormality and then send to a pediatrician at least. So starting with the craniofacial abnormality under the broader domain of neonatology, we are discussing that. And so first of all, in craniofacial, cranium has a very important structure that is called as fontanelle. So what is fontanelle? Fontanelle is actually the, I should say the gap. Okay, so this is the gap between the bones. So can you see, this is the bone, this is the bone, and this is the gap. All right, so this gap is called as anterior fontanelle because it is anteriorly located, and because it is this triangle is posteriorly located, so this is posterior fontanelle. You can see from the image very clearly that anterior fontanelle is diamond shape, whereas posterior fontanelle is triangular in shape. So these are the two most important fontanelles which are going to be there, although some other fontanelles are also be present. So whenever you palpate the fontanelle should be soft, the fontanelle should be flat. The fontanelle normally is soft and it should be flat. So as I have told you that anterior fontanelle is something which is located anteriorly at the junction of coronal sutures and metopic sutures. So can you see, this is the metopic suture which is there, this is the coronal suture which is there. So at the junction of the metopic and the coronal suture, I have got this diamond shaped gap, and this diamond shaped gap is called as anterior fontanelle. And posterior fontanelle is located at the junction of, this is the sagittal suture, this is the lambdoid suture, okay, sagittal and the lambdoid suture, and this is the fontanelle which is present. So posterior fontanelle is located at the junction of sagittal suture and of course the lambdoid suture. All right, so this is the posterior fontanelle. Now, as I have told you, it should be soft, it should be at the level, it should not be bulging. But if the fontanelle is bulging, if it is tense, you should be suspecting some intracranial pressure release increase, because if the intracranial pressure is high, my dear friends, this fontanelle is going to be tensed, it's going to be bulging because of the pressure that is coming from below. Whereas the another reason for the bulging anterior fontanelle, one is of course the increased intracranial pressure, the other is going to be some local pathology associated with it. Okay, so what can be the local pathology? The local pathology can be the local infections, and the local infections, just like any infection, any inflammation, can cause edema. Okay, so if I just tell you what are the causes of the bulging fontanelle, so the causes, in fact, for any pathology can be divided into COINS. COINS is the mnemonic. C for congenital, O for obstructive cause, I for infection, inflammation, N for neoplastic cause, and S for systemic cause. So see here, infection, of course the brain infections you must be aware of, meningitis, encephalitis and brain abscess. So you should remember infections. After that, the other thing is intracranial pathology like hydrocephalus. So hydro means water, cephalus means brain. So if any time the CSF in the brain is increased, that causes hydrocephalus. Of course, intracranial pathology also includes hemorrhage, because hemorrhage is again a lot of blood accumulated inside the brain, and that can cause the gap to be widened up. So the fontanelles are going to get widened, bulged, okay, tensed, right? And of course tumors also, because tumors are going to occupy the space, and if in fact for that matter cysts are also going to occupy the space, and then less space, more tumor cells, so they want to come out, they'll identify this gap, and of course this gap will be a protruding gap, because what? Because the underlying space occupying lesion. After that, you have got some systemic diseases like hypertension. Okay, so what happens in hypertension? Of course, there is a vasoconstriction, So this is the vessel, there is a vasoconstriction. So there will be increased pressure of the blood vessels, and this increased pressure of blood vessels leads to leakage of the fluid outside that causes cerebral edema, and once there is cerebral edema, of course, there will be tension generated in the fontanelles and the fontanelles will be bulging. Similarly, the states like venous obstruction, the same thing is going to happen, right? But sometimes this increased tension in the fontanelle can also because of some physiological reasons. For example, crying, coughing, lying down, okay? So if the baby is crying, exerting the pressure, so of course the fontanelles are going to be bulging. Coughing, again the pressure is going to increase and the fontanelle will bulge, okay? So these are the temporarily bulging conditions. These fontanelles, my dear friends, ideally they should close on a specific period of time. Just for example, I take the example of anterior fontanelle. Anterior fontanelle closes by 18 months, whereas posterior fontanelle closes by approximately 2 to 3 months. That's posterior fontanelle is early to close. Sometimes at birth also it is not open, it is closed only. But why anterior fontanelle? Okay, anterior fontanelle closes at 18 months. If you count the number of letters in anterior fontanelle, 1, 2, 3, 4, 5, 6, 7, 8, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 18 letters and 18 months is the time period. That means that anterior fontanelle is going to close by 18 months. If it is not closing, that means there is a delayed closure. Now, why there will be a delayed closure? Closure of the fontanelle means that the bone is going to, okay, this is normal. So closure means that the bone is going to occupy the space. Bone is going to occupy what? Bone is going to occupy the space. So any cause which is responsible for the delayed ossification, any cause which is responsible for the delayed ossification is going to be the cause of delayed closure of the fontanelle. Is going to be the cause of delayed closure of the fontanelle. For example, rickets. Now rickets in vitamin D deficiency, of course vitamin D is not there, so bone will be formed later, so there is a delayed ossification. Similarly, hypothyroidism, hypocalcemia, in both of these conditions the calcium is low, bone will be delayedly ossified, and of course the closure is going to be delayed. In osteogenesis imperfecta, the genesis of bone is impaired. Osteogenesis is imperfecta. So genesis is imperfect, so of course there will be delayed closure, right? Similarly, you have got achondroplasia. In achondroplasia, the things are going to be same. Hydrocephalus, of course the pressure is getting inserted, so there will be delayed closure, or you have the increased intracranial pressure because of hemorrhage, etc. And most important question, yeah, this is an important MCQ also, which infection is responsible for the delayed closure? That is going to be the syphilis, okay? So syphilis makes the closure slowed down. So S for syphilis, S for slow closure, okay? And S for one more thing, that is the storage disorders are going to be there. Coming on to sutures, I'm really sorry for this poor diagram, alright. So what happens? Understand this. So sutures, I've told you, sagittal, coronal, lambdoid, metopic. Let me just show you all these sutures. Yeah. So here it is the metopic suture, this one. This is going to be the coronal suture. This is going to be the straight one, the sagittal suture. This is the lambdoid suture, and if you carefully look at this suture is going to be the occipital bone occipital suture. Sometimes they say it is present, sometimes they say it is not present, but anyways sutures I have shown you. So sutures, please understand that they have to close. For example, this green one is one suture, this another one is another. They have to come close and fuse. Of course, they have to fuse. For example, they are trying to fuse. So what is the thing which is stopping them to get fused? This is the brain growth. Okay, this is the brain growth. So the brain is growing, of course. So both the ends are going to get far away because the brain is growing. Once the brain growth is stopped, of course, they are going to fuse. But for example, due to XYZ reason, they are going to fuse early, then the brain is going to grow. So the brain will grow on one side, not on the other side, because the fusion has taken place. That's why there will be asymmetrical skull. So the skull can be asymmetrical because of the passage through the birth canal. That's normal. The skull can be asymmetrical because when the child is passing from the vagina, from the birth canal, of course the one side of the brain can, the brain might occupy the one side and other side is not very much occupied. That's normal. But if it is persistent for 2 to 3 days, it is suspicious of craniosynostosis. So cranio means of course brain, syn means together, osteosis means formation of bone. So formation of bone, I mean the sutures are coming closer. Okay, so sutures are coming together. So this condition is called as craniosynostosis. That is one of the reason for asymmetrical skull. Why? Because there is a premature fusion of the sutures. Coming on to the next concept of craniotabes. What is craniotabes? See, craniotabes means in the parietal region of the baby. So whenever you see the parietal region of the baby, it feels like a ping pong ball when it is pressed. It is a ping pong ball like when it is pressed. Okay. So these ping pong ball appearance, this is actually normal in the parietal region, which disappears in approximately weeks to some months it might take. But if the child is having persistent ping ball appearance, it can be pathological because of syphilis as well as rickets, my dear friends. Coming on to what are the etiologies of cranial swelling, why the cranium is swelled up. This is our discussion topic now. So what are the common etiologies of cranial swelling? Please understand the common etiologies are two. One is going to be Caput Succedaneum, Cephalohematoma. Caput Succedaneum means this is a swelling that can cross the suture line. Caput Succedaneum is swelling that can cross the suture line. Whereas Cephalohematoma, hematoma simply means blood collection. It does not crosses the suture line. But what is important? Cephalohematoma is going to increase 12 to 24 hours after birth and it is going to get resolved within weeks to months. Whereas Succedaneum is successful because it is a maximum size at birth and it's going to resolve in some days. Now can you see this baby? You have to comment down that if it is Cephalohematoma or if it is a Caput Succedaneum in the comment section, and of course I will tell you the answer there only. Coming on to, now the cranium part is done, now we will discuss about the facial part. So facial abnormalities, one of the, not very common, but yeah, one of the abnormalities of face is facial palsy. So facial palsy means the 7th cranial nerve is involved, the 7th cranial nerve is damaged. So can you see that the 7th cranial nerve is damaged, that's why the child is not able to close the eyelid properly, and of course if you see here, there is a drooping mouth on the affected side. So 7th cranial nerve, if it is involved, my dear friends, please understand, this lesion is going to be on the same side. So what is happening? In facial palsy, what is the cause? Of course, birth trauma is the most common cause. Mostly spontaneous resolution is there and the neonates present with the drooping mouth on one side, and of course difficulty of feeding is going to be there, incomplete eye closure is going to be there, but on the same side. So my goal is to teach you everything related to pediatrics, and of course some important MCQs here and there I'll keep on discussing. So this is a very important MCQ, that whenever the 10th and the 7th cranial nerves are going to be affected, the defect is going to be on the same side of the lesion. Just like this side 7th cranial nerve is gone, so this side muscles are affected, that's why inappropriate closure and drooping is there. So remember, 10th and 7th cranial nerves on the same side, you have to remember how to remember S for 7, S for same side. Whereas if the 12th and 5th cranial nerve are involved, this is on the opposite side. Now why 10 and 7, 12 and 5? Because the total is going to be 17 for both of them. So it is easy to remember that 10th and 7th if are involved, the lesion will be same side of the defect, and if it is the 12th and 5th nerve involved, the lesion is going to be on the opposite side of the defect. Coming on to eye examination. So what happens normally in the eye, for example, if my eye, your eye, pediatrics eye, whenever you will put a torch light, you are going to see a red reflex. Why? Because the torch light is immediately going to go to the retina and it's going to get project back, and your retina is of course red in color, so you will get a red reflex. But for example, if an obstacle is going to come between the retina and the light rays, this obstacle is going to reflect back the white light, and this white light reflecting back is called as white reflex, and in the Latin word white is called as leuco, so it is called as leukocoria. So normally the red reflexes should be seen in both the eyes because the retina should be reflecting back the red color in our eyes, whereas if there is presence of any opacity or any white spot, it will lead to white reflex. And what is the mnemonic to remember the white reflex? The mnemonic is RTPCR. So R for retinoblastoma. Now retino means retina, blast means retinal cells, blastoma means tumor. So there is retinoblastoma, white reflex, leukocoria, that's going to be there. Congenital cataract, of course, affecting the lens. So lens is going to transmit the white light back. So congenital cataract, the lens opacity, it will give the white pupillary reflex. Coats disease. Coats disease is retinal telangiectasia. So retinal telangiectasia means that on retina there will be formation of some premature blood vessels. There will be formation of some premature blood vessels, and that leads to the breakdown of those blood vessels, that causes exudates to come, and these exudates are going to reflect back the light, that is responsible for leukocoria. One more important condition, persistent hyperplastic primary vitreous. Now what is this? See, actually it is a domain of ophthalmology faculty, but just I'll give an insight. So vitreous are of two types, primary vitreous, secondary vitreous. Alright, so you know na, vitreous humor, aqueous humor. So vitreous originally is of two types, primary vitreous, secondary vitreous. Primary vitreous is something that degrades. If it is not degrading, it is going to be persistent, called as persistent hyperplastic primary vitreous, of course. And this persistent hyperplastic primary vitreous is responsible for what? For the white spots, white reflex can be generated. Similarly, if the retina is detached, of course, there will be no red reflex which will be seen. And toxocariosis, white larva of toxoplasma is going to get is going to reflect that white light back. Alright. So RT-PCR, R for retinoblastoma, T for toxocariosis, P for persistent primary hyperplastic vitreous, C for congenital cataract, Coats disease, and R for retinal detachment. So in eye examination, what else are you going to see besides the red reflex? The sclera should be white and clear. Of course, the sclera, you know, should be white, should be clear. But sometimes there are some conditions where the sclera is blue. Why? See, the sclera is nothing but the connective tissue only. If the sclera is not being formed properly, you will see what? You will see the underlying blue veins, and this is the condition which is seen when the connective tissue is not formed properly. The name of the condition is going to be osteogenesis imperfecta. Osteogenesis means connective tissue formation. If the connective tissue is not formed properly, there will be osteogenesis imperfecta, and that leads to blue sclera. Because sclera is not formed, so the underlying blue veins will be visible, so that leads to blue sclera. Coming on to the palpebral fissures. What is palpebral fissure? So this is upper eyelid, this is lower eyelid. So the fissure in between both is called as palpebral fissure. So these palpebral fissure can be narrowed, okay, narrowed, just like this narrow palpebral fissure. Oh my god, I can't see it. So this narrowed down palpebral fissure is seen in the Digeorge syndrome or the Downs syndrome, okay. So if you know the catch-22 mnemonic for Downs, you know the C is actually the craniofacial abnormalities. So craniofacial abnormalities is going to be there, and that is the abnormal palpebral fissure, the narrow fissure which is seen. Alright. Symmetry. Sometimes the epicanthal folds. So see, if I talk for the eye, this is the medial canthus, lateral canthus, and above this canthus there is an epicanthal fold which can come, which can be there. So this prominent epicanthal fold is going to be visible. So there will be asymmetry if this epicanthal fold is present on one side. This happens with trisomy 21. Trisomy 21 is Downs, and D and E are very close alphabets in your alphabetical series. So D and E, that means Downs is going to have the epicanthal folds, prominent epicanthal folds will be seen. Coming on to spacing, hypertelorism. So see, very simple, very easy to understand. Supposedly this is my one eye, this is the another eye. So in between both the eyes there is a normal gap which is going to be there. A normal gap which is going to be there. If this gap is increased, this causes widely spaced eyes. If this gap is increased, this causes widely spaced eyes, which is associated with large number of syndromes, and one of the syndrome is going to be 13. That's going to be which syndrome? Trisomy 13. So T for 13, T for Taylorism. Alright, easy to remember, good. After that, can you see this? That the amount of gap, yeah. So this can be associated with what? This can be associated with your trisomy 13, and trisomy 13 is called as Patau's syndrome. This is called as which syndrome? It is called as Patau's syndrome. Okay. Coming on to congenital cataract. Now understand that congenitally some cataracts can be there. For example, a special type of congenital cataract that is called as oil dropped cataract is seen in galactosemia. So galactosemia is nothing else but the galactokinase deficiency. So remember, a specialized type of congenital cataract that is called as oil droplet cataract that is seen in galactosemia, especially in the galactokinase deficiency. Can you see this oil droplet? Yeah. This is because of galactokinase deficiency that the galactose is going to get accumulated. The galactose is going to get accumulated, will be deposited in the lens, and it is responsible for causing congenital cataract. And the easy way to remember is, remember this is C, this is G. So C and G look very similar, and if I just combine C and G, this leads to the formation of O. So O is going to be oil drop cataract. Right? Coming on to ears. Now in ears, my dear friends, please understand the term infants are going to have firm ears. The term infants are going to have firm ears, but sometimes there is a so this is auricle, ear, and there is this is ear, and there is a pre-auricle area. So there can be skin tags and sinuses which are going to be present. So you have to look out for the skin tags and the pre-auricular sinuses, because these sinuses sometimes might be having pus, might be having infections. So you have to look out, because the baby is itself a mystery. Your young patients, adult patients are going to come with the history. My babies come with only the mystery, because baby can't tell you now what is happening. He'll only cry, cry, cry and cry. Okay. Coming on to the nose. So see, sometimes what happens is, so these are the anterior nares, and posteriorly you have got the posterior nares. This is the anterior nares, that is going to be the posterior nares. What is going to happen? Sometimes the posterior nares is going to show the atresia. It is going to show the blockage. So it is not formed properly, blockage. So if it is blockage, the child will not be able to breathe in properly. That's why you have to check if there is any blockage. How? By passing the nasogastric tube. If the nasogastric tube easily passes, that means there is no blockage. If it is obstructing, then that means it is having a blockage. Alright. Coming on to mouth. Now in mouth, of course, the main issue is going to be about the cleft palate, the cleft lip. Alright, these are the issues which are there in the mouth. Whereas there is something which is called as 𝗵𝗵𝗵𝗵. That's a physiological finding, which is a small white lesion. Okay, small white lesion that is present on the palate. Small white lesion that is present on the palate. This is called as 𝗵𝗵𝗵𝗵. Alright. Coming on to the chin. So what is chin? Micrognathia. So this is a small chin. Micrognathia means, micro means small, gnathia means chin. So small chin is going to be there in what? It is going to be there in the Peyri-Robin syndrome. It is going to be there in Beckwith-Wiedemann syndrome. It is going to be there in Edwards syndrome. It is going to be there in Treacher-Collins syndrome. So it is there in Peyri-Robin syndrome, Beckwith-Wiedemann syndrome, Edwards syndrome, Treacher-Collins syndrome. I know the names are difficult. Just pause the video here and try to, read these names 1, 2, 3, 4 times, and of course you will be having it in your memory. But the way to remember is, let's have a small bet. Okay, so have a small bet with me. I am Perf. P for Peyri-Robinson syndrome. Bet. B for Beckwith-Wiedemann syndrome. E for Edwards syndrome. T for Treacher-Collins syndrome. Small means micrognethia. Whereas you have got macroglossia. Macroglossia means you have got enlarged tongue. Now, macroglossia, understand, small chin and large tongue. So, Beckwith-Wiedemann syndrome is an example of small chin and large tongue. How to remember? Wiedemann, wide tongue is going to be there. Beckwith, something is coming on the back. Why? Because it is small. Okay. So, smaller things, you should keep it in, actually you should not keep in back of your mind. So, Beckwith-Wiedemann, small chin, Beckwith-Wiedemann syndrome. Okay. And of course, wide tongue, Wiedemann, right? Similarly, in hypothyroidism also, the chin is small and the tongue is large. So, the tongue is out in them, protruded tongue we call it as in the hypothyroidism kids. Of course, in endocrine part of pediatrics, we'll discuss that. But remember, the kids who are having hypothyroidism are called as cretinism kids. They are having cretinism, okay. So, infants with hypothyroidism, cretinism, and the tongue is going to be out. Similarly, you have got a mucopolysaccharidosis. Similarly, in mucopolysaccharidosis, so what is happening? There is increased amount of mucopolysaccharides which are going to get developed into the tongue, and the tongue will be enlarged, okay. So, what is happening? The macroglossia, that means enlarged tongue. Why? Because of increased amount of mucopolysaccharides, there is enlarged tongue. So, yeah, this is all about the craniofacial abnormalities, and I am very much thankful to you for watching this video till the end. God bless you. Keep learning, stay happy, stay focused. Thank you.